your speech. You can go live now.
Good evening, doctors. On behalf of Hitro Healthcare, I, Dr. Prashant Khandeparkar, welcome to you to this webinar on role of melatonin in PCOS management. Doctors, as you know, at Hitro, we market products in multiple therapy areas like in dermatology, gynecology, orthopedics, pulmonology, etc. We have very strong R&D support, which is why we have developed many unique formulations keeping patient benefit in mind. Our endeavor is to develop products, formulations, and combinations which will finally improve patient compliance and ultimately clinical outcome. We have developed NSAID patches, reverse treatment patches for patient compliance. At Frenza division, gynecology, obstetrics, and IVF is an important therapy segment for us. We market products for vaginal health like Feminora. We have formulated and introduced vaginal film containing lactic acid. In oral formulations, besides dydrogesterone, Dydropal, and other products, we market Melatonin, a unique nutraceutical for PCOS management. Melatonin contains myoinositol and dechiroinositol in the ratio of 40:1, chromium picolinate, folic acid, and vitamin D, along with melatonin. We know that melatonin role in PCOS is well documented and is getting increasingly accepted. To speak more about PCOS management and PCOS and management with nutraceutical containing melatonin, we have leading KOLs, Dr. Asha Baxi and Dr. Dhaval Baxi. Dr. Asha Baxi is chairperson for today's session and Dr. Dhaval Baxi is the speaker. Madam, Dr. Asha Baxi is MS FRCOG and MRCOG London. Currently, Madam is Secretary for ISAR, Member of Executive Committee AICCR-COG, West Zone, Member of Advisory Committee PCP-NDT, Indore, Founder Person MPI, AGE and SR. Madam is credited with first ICSI, TESAI, TESAICI, and Micro TESC, ICSI babies of MP. Dr. Bakshi is the recipient of Tamaskar Award Foxy, Padma Shri Dr. Mukherjee Award, Excellence Award from Dainik Bhaskar. Madam has organized several conferences, like, just to give an example, Star Endogyne 2019, AICOG 2022, etc. Madam has several publications to her credit, both in the national journals and international journals of repute. Dr. Bakshi has authored several chapters in newsletters and textbooks. Welcome, Madam. Welcome, Dr. Asha Bakshi. To introduce Dr. Dhaval Baxi, Dr. Dhaval Baxi, the speaker for today, is DNB MCH Gold Medalist, is currently consultant fertility specialist at Motherhood Hospital, Indore, and Disha Fertility and Surgical Center, Indore. Dr. Dhaval Baxi is certified reproductive endoscopic surgeon in both basic and master level. Has undergone advanced endoscopy training. Has published several papers in national conferences. Just to name, paper Endometrial Carcinoma, a shocking diagnosis in women with secondary infertility, won the Best Paper Award. Dr. Dhaval Baxi is also winner of several awards for best paper publications in endoscopy. He is invited speaker for various organizations, for various programs like ISAR Bengal Conference 2016, Indore Obstetric and Gynec Society Workshop 2017. Welcome, Dr. Dhaval Baxi, and over to you. Over to you,
Thank
Madam.
You. So thank you very much for the kind introduction, and without wasting much time, let's just jump directly to the presentation. So today we're going to be talking about the role of melatonin in PCOS management. Just sharing the screen. Yeah. So we all know that polycystic ovarian syndrome is a very common disorder that we see in our everyday clinic, and we all feel, whether it is infertility, whether it is general gynecology, even in the endocrinologists, all of them and even the dermatologists are encountering cases of polycystic ovarian syndrome. And if we look at the statistics, so it is almost every 1 in 5 women in India suffering from PCOS, and the prevalence is up till almost 22.5%. And especially in the adolescents, some studies have reported a 36% prevalence in adolescents. However, with the latest, most of these studies are a little bit old and they don't use the current WHO guidelines for PCOS diagnosis. So now with the change in the definition and how to diagnose it, especially in adolescents, I think if the same studies are done again, the prevalence in adolescents might go down, but definitely yes, uh, it is widely prevalent amongst the adult patients as well. So once again, India is one of the highest India is one of the countries with the highest self-reported diagnosis of PCOS. Although once again, I would be a little skeptical, because a lot of these women, we are quite liberal with our ultrasound, and a lot of women, when they go for an ultrasound, if the clinician says, if the radiologist reports it as polycystic ovaries, so then they get the diagnosis of polycystic ovaries. So it might be just worthwhile just doing all of these surveys once again, with the newer definitions and with the newer data. So we all know that PCOS is a hormonal disorder which is common amongst women of reproductive age, and the ovaries develop numerous small immature follicles, and it is all characterized by anovulation. So polycystic ovary has got its name when Steen and Leventhal did the wedge resection, and then on the gross appearance of when the oophorectomies were done and the cut section was taken. So then they saw a lot of multiple small cysts, and that is how polycystic ovarian syndrome got its name. So, but basically there are no cysts per se, but it is all multiple immature follicles, and present bilaterally in most cases. So, what is the hormonal imbalance that occurs? Is basically there is a hypertrichosis in PCOS. Hypertrichosis leads to excessive LH formation. Excessive LH formation will lead to excess conversion of the estrogens into androgens, and there will be hyperandrogenism. Hyperandrogenism leads to an increase in insulin and an increase in insulin resistance, as well as and hyperinsulinemia, obviously. So, but the key feature that we see here is insulin resistance in both obese as well as lean PCOS. In both the phenotypes, insulin resistance is quite common, and is obviously much more higher in people with obese PCOS, because the insulin resistance will lead to other metabolic changes in the body, but still it is quite commonly prevalent in lean PCOS as well. That is why whenever our patients come, even if it's a lean patient, we would ask them to exercise and alter the diet a little bit, just to help in improvement of their insulin resistance. Yeah. So the normal hypopituitary, the HPO axis, basically the hypothalamus will secrete the GnRH, and which acts on the anterior pituitary, leading to FSH and LH production. LH will act on thecal cells and lead to an increase in the androgens. These androgens will then go and migrate into the granulosa cells, and under the effect of aromatase become estrogens and go ahead and lead to the oocyte development. But this is what I have said earlier, that in PCOS the LH secretion is elevated, while the FSH remains the same or is even reduced in sometimes. And that is why the classical definition of the ratio of 2:1 was there. And many a times that was how we diagnosed in the earlier days, but now with the evolving criteria, so things have changed now. So the LH will stimulate the theca cell proliferation and secretion of androgens. But the problem is that there is insufficient FSH to stimulate the granulosa cells. So what happens is then the granulosa cells, since they do not proliferate as much as the theca cells do, so there is no migration of the androgens into the granulosa cells, and the estrogen levels do not go up to the same level as the androgens do. And because estrogen uses androgens as a precursor, and then under the influence of aromatase will lead to production of estrogen. So when all of this excess androgen is there, so then this will all enter into the circulation and cause hyperandrogenic features like hirsutism, acne, etc., etc., etc. So hyperandrogenism, we all know, causes amenorrhea, oligomenorrhea, hirsutism, obesity, acne, and as well as hair loss. And insulin resistance is also a key feature here, because the androgens also lead to an alteration in the insulin resistance levels. So basically what we see is that the fasting insulin ratio is much higher in these patients. And this insulin resistance will also contribute to a lot of other things like acanthosis nigricans. So basically, in your patients in your clinic, if you can see that the neck, if there is some dark discoloration, so then those are the patients in which you should suspect that there are features of insulin resistance as well. So what all does PCOS lead to? It leads to infertility. It can lead to patients may have gestational diabetes or PIH. There may be miscarriages or premature births, miscarriages because of the poor oocyte quality. In a longer term, if you look at the long-term outcomes, which is very important to look at as well, because sometimes as gynecologists, we only look at the reproduction part, but we fail to counsel our patients regarding the long-term effects. So women with PCOS are more prone to develop MASH, which is non-alcoholic steatohepatitis, and also metabolic syndrome. So metabolic syndrome is the dangerous one, because metabolic syndrome will then have its other side effects. So metabolic syndrome is basically high blood pressure, high sugar levels, and abnormal cholesterol levels, and this leads to an increase in cardiovascular disease. So this is very important, and in women nowadays, many cardiac problems are going unnoticed and unrecognized. And so, we have to keep a look, and maybe it is because of this high prevalence of PCOS. Longer term, patients are more prone to developing type 2 diabetes or prediabetes, depression, anxiety, and eating disorders. All of them are interlinked. A lot of these women have their own, they have their body composition issue disorders, and they all have complexes where they feel that in case they have hirsutism, in case they're gaining weight, they all are feeling a little bit depressed about all of that. If they're not able to conceive, again, is another cause for depression. And usually to combat this depression, people tend to overeat and have these eating disorders. Abnormal uterine bleeding because of the anovulation and the increase in the thickness of the endometrial lining, it may lead to abnormal uterine bleeding. And endometrial cancer is quite common in these patients. In two of our infertile patients, we've actually picked up endometrial carcinoma, which was masquerading as a polyp. So when we did an hysteroscopy in these women with thick endometrium, and we sent biopsies, it turned out to be endometrial carcinoma, and they, rather than undergoing treatment for infertility, they ended up in a radical hysterectomy. So this is one thing that we have to always, keep in mind, that in patients who have PCOS, long-standing, especially in the ones who have severe anovulation, always think about ruling out of endometrial carcinoma in case you find that the endometrium is persistently thick. So usually nowadays, it is the diagnosis of PCOS is by signs and symptoms as well as your ultrasound. So the three main features are anovulatory cycles, which are characterized by irregular cycles, polycystic ovaries on the ultrasound, and as well as clinical or biochemical features of hyperandrogenism. And as per the Rotterdam criteria, at least two of these features should be present for women to be diagnosed with PCOS. And depending upon these three criteria, there are various phenotypes of PCOS. So there's type A, type B, type C, and type D. So depending upon the permutations and combinations, whether two of these symptoms are present or whether all three of them are present. So the patients have been also characterized into various phenotypes. So when we look at what we want to do when we're treating these patients, so our goals are basically to regulate the cycles in some set of women, improve the insulin resistance, which will then lead to weight loss, or weight loss will lead to improvement in the insulin resistance. Both of them are interlinked. improvement of fertility in patients who are infertile, and an overall decrease in androgens all will happen hand in hand. So that is there. The only thing that we have to realize is when these women come with hyperandrogenism and acne, whatever treatments we do will help in prevention of further worsening. But in case they've already developed those thick androgenic hair over the face or anywhere in the body, those all will need all your laser treatments for removal. Management of PCOS includes lifestyle changes, which, in my opinion, are the easiest thing to say, but the most difficult thing to do in real life, because these women are already battling so many problems in their day-to-day thing, and it all depends on their motivation. Sometimes, if fertility is the goal, these patients might find the motivation to go ahead and create the lifestyle changes. And lifestyle changes, if they do it, have a lot of benefits, not only just for fertility, but for their overall long-term well-being. In case lifestyle changes do not work, then we can always put them on medications as well as dietary supplements. So medications include oral contraceptives, anti-androgens like clomiphene. There are gonadotropins and metformin, so, and as well as aromatase inhibitors like letrozole. Anti-androgens are there, spironolactone, which thiazolidinedione, which are again insulin sensitizers, and eflornithine. So this is basically an anti-androgen cream to slow down the facial hair growth. So this is all that chart. So this is just a small algorithm in which from the American Society of Family Physicians, which has been suggested. But apart from the US FDA approved medications, there are many supplements which are present. So, and these usually include vitamin D, resveratrol, lipoic acid, omega-3 fatty acids, berberine, folic acid, myoinositol, and D-chiroinositol. And myoinositol and D-chiroinositol are essential and well-studied supplements for PCOS, and they all act by increasing their insulin resistance, insulin sensitivity, and reducing the insulin resistance. So when the combinations of the two are used, so they can cause increased frequency of ovulation, reduced need of FSH therapy for decreasing the ovulation, and a significant improvement in the pregnancy rate. So, now coming to Melatonin in specific. So the formulation contains myoinositol, D-chiroinositol, chromium picolinate, folic acid, melatonin, and vitamin D. So all of the components here are being addressed. So now just talking about myoinositol and D-chiroinositol. So usually what happens is in polycystic ovaries, there is a huge decrease in the levels of myoinositol, and follicular development is impaired because of this lower myoinositol levels in the ovaries. And because this is all leading to an increase in the insulin resistance. So when these combinations, etc., are used, so there might be improvement in the insulin resistance, and that is why this combination has been proposed. So the physiological ratio of myoinositol and D-chiroinositol is 40:1, and therefore that is why this is the combination that is being given. Myoinositol. So the specific functions is basically D-chiroinositol will inhibit the aromatase synthesis and increase the androgen synthesis under the insulin stimulation. Myoinositol will modulate the PI3K activity while enhancing aromatase and FSH receptor synthesis in the granulosa cell. So this is all basically, there needs to be a good balance which has to be achieved between the two, and this is why once again the ratio is there. The 40:1 ratio is there to do that. Chromium picolinate is basically acts again as an insulin sensitizer, and it reduces hyperinsulinemia and hyperandrogenism. Folic acid we all know, and vitamin D also plays a keen role, because in a lot of women with infertility, vitamin D deficiency in itself is a huge huge topic that has, everything that we are now seeing has some implication about vitamin D, especially in women with reduced ovarian reserve, women with PCOS. A lot of women have a lot of problems, and there are studies in which have shown that in women with a poor ovarian response, if you've supplemented them with and who have vitamin D deficiency, if you've supplemented vitamin D to them, so then in the subsequent cycle, the outcomes are much better. So coming to melatonin, concentration of melatonin in the pre-ovulatory follicular fluid is lower in women with PCOS. And melatonin, basically what it does is it supports the nuclear maturation of the oocytes. So so a study by Kim et al. Came out, and they had suggested that myoinositol administration may be useful in IVF in patients undergoing IVF, because they saw a better maturation of the oocytes and leading to a improvement in the pregnancy rate. Yeah. So ESHRE basically has the ESHRE guidelines which had come out earlier, and the ESHRE, ASRM, and WHO had come out with a joint consensus statement. And what they have said is that anti-obesity medications could be considered in addition to active lifestyle intervention for the management of higher weight in adult women with PCOS. So basically, but what they're also recommending is that first thing that you have to do is the active lifestyle intervention, and then add all of these anti-obesity medications like inositol, etc. And it all depends on your individual preferences, and you have to explain the harms and the potential of what can happen, and also look at the cost, because the cost is also an important thing. So, so you have to balance. In some patients, in which you're really suspecting that there is insulin resistance, maybe you can give it to them, and the others you can, you have to choose accordingly and tailor make it. So this is another study in which they supplemented melatonin in women with PCOS. So what they saw is that in women, because of the when melatonin was supplemented, so what happens is there was an improvement in the metabolism of the women, and the whole overall metabolic function, once it improved, that reduced the insulin resistance, and reducing the insulin resistance will improve all that IGF-1 and IGF-2 mediated folliculogenesis, and lead to improvement in the improvement in ovulation. This again is another study in which they concluded that giving myoinositol combined with melatonin improved the ovarian stimulation protocols in women with poor oocyte quality. So this is all women who've already undergone IVF, they've had poor response, and then they've supplemented all of these things and lead to improvement in the IVF, in the fertilization results. So all of these studies are quite similar. And so just before signing off, I'd like to say that all of these insulin sensitizers do have a role to play in modern day clinical practice. And but you have to be judicious in which patients you want to prescribe them and which not, while balancing the cost as well as the overall effectiveness at the same time. And apart from all of these things, I think a good psychological evaluation as well as conversation has to be done with these patients, because it's not only fertility that they're battling, but PCOS, women with PCOS have many other challenges, and maybe sometimes just some motivation might help them improve their whole lifestyle, and sometimes it just makes a huge difference. So thank you very much to the team from Hetero Healthcare for giving me this opportunity. And I think now we're going to do the question answer session with Dr. Asha Baxi, madam.
Thanks,
Thank you
Dr.
very
Dhaval.
much, Dhaval, for the presentation, and you have really impressed upon for the on PCOS topic. And PCOS is really important. And though we all are inducing these patients, giving ovulatory induction, but certain adjuvants are required. And we all have seen that many times you do IVF and the egg quality is very poor. Many a times these patients, they don't want to. In India, people, you say कि नहीं आप diet करो, so diet they don't want, but they'll say you give us some medication which can help. So here is this medication that helps many symptoms also, because PCOS has got lots of symptoms also, weight, then excessive androgens. So there are all these small things. So many adjuvants are there in these type of medication, and they are having various actions. Ultimately, their aim is to reduce the androgens and to reduce the and to improve the insulin resistance. So that's one very good thing about these combinations and adjuvants. I do believe a lot in adjuvants. Adjuvants along with lifestyle modification and ovulation induction agents really does wonders. So I do believe in adjuvants. And melatonin recently is picking up, and we have seen yes, you did talk about that melatonin has got antioxidant effects, and it does improve the quality and all those things. One more thing about melatonin that I have found in my day-to-day practice is that it helps in psychological, it has got some effect on psychology of the patient also. And those patients who have problems with sleep, then it improves their sleep cycle also. And we do understand that melatonin is something which is related to the circadian rhythm. Okay, so this circadian, and we know that with the darkness, the melatonin improves. So this circadian rhythm has been found to be bad with the women who have got PCOS, and improving, and they have lots of sleep problems. So if you give melatonin, that helps in good sleep also. And melatonin is all these days being taken in use in so many situations. Even in pregnancy, people are recommending. So I'm sure that small effects are there. And somewhere I was reading that melatonin reduces the microscopic symptoms of PCOS. So I liked this sentence very much. And it has got again anti-cancer, antioxidant, anti-angiogenetic, and it is immune modulator also. So all these combination, and myoinositol and inositol, I think we have been using them, and patients don't feel that they are taking medication. They feel that they are taking nutraceuticals. So that has got its own impact as well. So with this, I think, yes, you have done justice to the talk, and adjuvants are a thing to be used, and we all are using it.
Thanks, madam. Thanks, Dr. Dhaval. That was lovely. I completely agree, madam, about the role of melatonin. In fact, melatonin levels do go down in the follicles in patients suffering from PCOS.
Yes.
Secondly, what they say is the white light which comes out of mobile and which comes out of laptop also affects melatonin secretion, and consequently, melatonin secretion being affected, it will finally lead to PCOS, insulin resistance, etc. It is also said that people working in the third-party centers or night shifts, the ladies working especially, what will happen is that because of the circadian rhythm being disturbed, the melatonin secretion gets affected. Very correct, madam. There have been few questions. I'll just ask it.
Yeah,
These type
I
of
would like
formulas.
to add a point that maybe
Yes.
because since when we're supplementing melatonin, I think so maybe we should give it at night time, so that
Absolutely.
that leads to improvement
Absolutely.
in the sleep
Completely
quality.
agree.
Otherwise, if you give it in the daytime, so then
Correct.
they might feel a little drowsy, and that might
Correct.
further
Correct.
disturb their circadian rhythm.
It's a
So
wonderful insight,
maybe
doctor.
we should give it at night.
Correct. Doctor, generally these type of formulations you give for how long?
At least for 3 months. I don't
3
think if
months.
you give it for less than
Correct.
3 months, it is going
Correct.
to
It will
help.
make
So
no. It will make
because
no.
these are all means the effects are
Nutraceuticals.
not that miraculous that within few days you'll get. So you need it's not just giving the medication. Along with that, you have to really pay a lot of stress on lifestyle management. In my clinic, I tell them first go and do cycling, and then come and come for your ovulation study. So you have to be really strict with these patients and check the weight and everything. But of course, you have to encourage. Don't be after them and nag them, because that can have a negative effect also. But then you have to encourage them to lose weight.
Many times in our country, for different. Yes, doctor.
Yeah. Also, we have to realize that minimum 3 months is because There is a
Absolutely.
gonadotropin independent period of folliculogenesis, which starts 3 months prior to the ovulation. So that is why it is very important to give things for at least 3 months, because that is when they're actually going to start acting upon, and the results will actually reflect in the follicular fluid.
Doctor, how do you feel? How common is infertility in PCOS?
Dhaval, you want to answer?
I think it is quite common. It also depends on maybe I think around 20 to 30% of women with female factor infertility have PCOS. So I think it is quite common. Yeah.
That's quite, yeah.
Our clinics are full of either PCOS patients or patients with reduced ovarian reserve.
Yeah,
These
it
are
is the opposite
patients
spectrum
with-
mostly.
yeah.
Correct. And would it make sense to give this type of product before starting an IVF cycle?
Yeah, means what we do usually is we start it at the same time, because what happens is you can't wait for the patient
No, you can't.
for these drugs to have. But naturally, these are the patients who have been coming to us, and initially we try IUI and we try lifestyle modification. We ask them to try naturally. So for that time, yes, it is work. But you can't just ask them to wait for IVF for 3 months, first give this medication.
Yeah.
Even for weight loss, if the weight is, she's not morbidly obese, then I ask them to reduce the weight. At the same time, I continue to treat. Because what will happen is it's so difficult to reduce the weight.
Absolutely.
And for when next time she will come, she will add another 6 kgs. So better to start the treatment at the same time.
Many times in our country, lifestyle measures are more aspirational than practical. We cannot, for various reasons, we cannot go through it. One more thing, doctor, have you seen any adverse effect with these type of products if taken for long?
Not yet.
Not
Not
yet.
a single patient. Not a single patient has till now reported about adverse effects. When it is in combination with metformin, then
Obviously.
patients complain of, I mean to say, indigestion
That's
and low
correct.
motion,
GI symptoms.
and all the GI.
But are you able to postpone the metformin treatment if you give this with chromium picolinate, or a delay metformin treatment?
You can, but
maybe it may not be in all
depends on
patients.
the-
But yes, it may not be in all
It depends on
patients.
the severity as well.
Correct. Anyway, thank you, doctors, both of you, for wonderful insights. It was lovely, sharing clinical experience with you all. Lovely. Thanks once again.
Okay.
And I thank all the doctors who took time from their busy schedule and commitments and attended this
Any
webinar.
questions from the doctors? Are
Yeah,
there
this is what have been coming.
Okay.
Okay.
Then from the busy schedule and commitments, thanks marketing team Hitro for conceptualizing and organizing this webinar. As you'll all agree with me, this type of program requires coordination from the field, and thank you Hitro field personnel for super coordination. Last but not the least, thank you IT team Hitro for your support and guidance in all technology related matters. Thanks once again. Thanks all of you. And doctors, if we get questions from the field, which actually we may not get directly now, but we may get at a later stage, we'll definitely bounce it off with you all and take your insights on them.
Sure.
Thank you so much. Have a pleasant evening. Lovely. It was nice meeting you.
Thank you.
Thank you, Dhaval sir. Thank you, Asha ma'am.
Thank you.
Thanks, Priyanka.
Thank you, sir.
Thanks.